We're pleased to have Dr. Raabia Ahmad, our El Camino Heart Failure Program Medical Director, who joined our community in 2021. You probably didn't want me to do your whole bio, but I'm glad she's here. She moved out from the East Coast. She was at the Mass General Brigham system, and in addition to her clinical duties, she also serves as the president of the Advanced Cardiovascular Specialist Group. So we're glad to have her. Now joining her are two specialists. We have Dr. E.J. Kim, who is an electrophysiologist. You'll learn more about that, but basically it's these people that look for the arrhythmias in our heart and treat them. And then next to her, or him, her is Dr. Fady Ibrahim, who is a structural heart interventional cardiologist who uses minimally invasive transcatheter-based technology to treat valves and other structural heart issues. So what we're going to learn here is what are these cardiac causes that could lead to stroke, and we look forward to that discussion. Thank you.
All right, thanks, Josh. So we're really going to be focusing on one of the most common cardiac causes of stroke, which is atrial fibrillation. There are a lot of different causes of stroke, other heart conditions that can lead to stroke, but for our purposes, we're going to talk about AFib, which is incredibly common, and we're going to start off just talking about using a case presentation, which in our practice we see quite often in the hospital and in our office. So this is a 73-year-old woman who has a history of sleep apnea. She has obesity, she has hypertension and diabetes. She comes into the emergency room complaining of shortness of breath and palpitations that have been going on for the past 2 weeks. The night of the admission, she couldn't lay flat to go to sleep, and her husband brought her to the emergency room. Her EKG showed atrial fibrillation with a heart rate of 140 beats per minute. So, Dr. Ibrahim, you're on call for general cardiology. You get called by the emergency room doctor. What are your first thoughts about this patient, and what would you recommend right off the bat in treating her?
Sure. Thank you, Raabia. I hope this mic sounds okay. All right. So there's a few things that come to mind, and this is a very common scenario we encounter. No matter what hour of the day, atrial fibrillation is quite common. But there's two main issues that would come to my mind if I was receiving the phone call. First thing being, as you heard, she's experiencing palpitations. As the EKG will tell us, the heart rate is very fast. It's about 140 beats a minute here in this scenario. So we have to do something to control the speed of the heart. So there's a variety of medicines, a lot of them intravenous, some of them oral, that would help us to address the issue here and hopefully help her feel better. The other thing we'd have to deal with here, she is short of breath. She probably has water built up in her body. So we have to work also on dealing with that fluid in her system. And so with that, there's also medicines, diuretics, that we give intravenously and orally to help us control the hemodynamic system and help her feel better eventually. But that is also important for the short term, and then there's more questions for the long term.
Great. So, Dr. Kim, can you explain a little bit more about what atrial fibrillation is and a little bit more about how we treat it?
Sure. So atrial fibrillation is actually this really rapid, disorganized arrhythmia that comes from the left upper chamber of the heart. And it's actually turned out to be one of the most common rhythm problem in this country, actually worldwide. And in America, it's affecting currently about 10 million Americans, actually, at the moment. And when we think about the risk factors for the atrial fibrillation rhythm issue, one of the major risk factors is age. So we know that actually 1 in 3 Americans who are 7 years or older actually carry the diagnosis of atrial fibrillation. It is that common. Other than that, also, any sort of risk factor you think about that increase the risk of the heart disease in general also increase the risk of atrial fibrillation too. So for instance, high blood pressure, diabetes, obesity, also untreated sleep apnea, is also linked with atrial fibrillation as well. All these risk factors actually elevate not only the risk of a heart disease in general, but also increase the risk of atrial fibrillation. So if we think back to our case, our patient did have some risk factors. She's a little bit older in age, and she has high blood pressure, diabetes, she has obesity, and the sleep apnea. So all these risk factors can probably explain why she has atrial fibrillation.
Great. So, yeah, I think age is the most, common cause of atrial fibrillation. People always ask what led to this, and could I have done something differently? And we always say you can't prevent getting older. And it's just something that comes up. Obviously, there are some risk factors, but it's just one of those things that happens, and we deal with it so commonly. So one of the most common questions that I get from patients is atrial fibrillation dangerous for me, and can I die from atrial fibrillation? Can you answer that?
Yes, I also get that question all the time. Is this gonna kill me? And my answer to that question is, atrial fibrillation is not in itself a fatal rhythm in a sense that it'll kill you directly. But certainly it's associated with so many other heart problems or other health issues linked with AFib if it's left untreated. So for instance, stroke is one of the major complications that can happen with untreated atrial fibrillation, and also heart failure as well, as you saw in our patient. If I go in, yeah.
You want to talk about
Yeah, so if I actually go in a little bit further in terms of then how does AFib cause stroke? So when you go into atrial fibrillation, what's happening in your heart is that the upper chamber is beating chaotically fast, like over 350 beats per minute. So you can imagine that heart chamber is pretty much quibbling when you're in atrial fibrillation rhythm. And there's really no effective blood circulation when heart is just not pumping effectively. And that causes the pooling of the blood and increased risk of blood clot formation inside the heart. And when that gets dislodged out of the heart and go into the brain, that's how the stroke happens. So having the atrial fibrillation diagnosis, plus we also look at other risk factors for stroke in our patients. If we think the risk is high enough, then we do recommend starting a blood thinner medication to really mitigate that risk for our patients.
So how do you decide who you're gonna put on blood thinner and who doesn't need to be on blood thinner when they have atrial fibrillation?
Great question. Yeah. So there are few different risk stratification tools that we use, but one of the most common one is actually called on the screen CHAS-VASc score, and that's an acronym that stands for C for heart failure, H, high blood pressure, age, both 65 or older or 75 or older. There's diabetes, prior stroke history or mini stroke history, and any kind of vascular disease, whether you had a coronary artery disease or vascular problems elsewhere. And also being a female, turned out, once you have a diagnosis of AFib, it is a risk modifier. It actually increases your risk of stroke further. So we use this tool to estimate what is the stroke risk for our patient, and then we make that decision. So if we actually go back to our case, our patient was 73-year-old female, and she's a female. She gets that 1 and 2 points there, and then also she has a high blood pressure, diabetes, and now we know that she does have a heart failure condition. That's how she came to the ER. So she does get 5 points in terms of the risk calculation, and that projects about 7.2% chance of stroke annually for this patient. So we would recommend starting her on a blood thinner in this case.
Excellent. Okay. So I did want to talk a little bit more about what you mentioned about heart failure. So how does atrial fibrillation cause heart failure? There are two main types of heart failure. There's heart failure with reduced ejection fraction, where the actual pumping of the heart goes down. And in this case, sometimes atrial fibrillation, either from the heart going too fast or from the heart muscle just pumping inefficiently, people can actually develop a reduced ejection fraction from atrial fibrillation itself. The other type of heart failure, which is more common, is heart failure with preserved ejection fraction. This is the most common in people who have risk factors of obesity, hypertension, where the heart muscle itself, the pump is working okay, but the muscle is thickened and the muscle becomes stiffer, which happens on its own with age. And so the heart is not able to fill in order to expand and let blood flow into the heart to then be pumped out. So it backs up into the lungs, it backs up into the belly, backs up into the legs. So in our case, this woman had difficulty laying flat called orthopnea, where there's fluid in the lungs. When they lay down, that fluid goes, makes them have difficulty breathing. She had swelling in her legs. The weight often goes up. These are all signs and symptoms of congestive heart failure. So when people go into atrial fibrillation and they have these stiff heart muscles, oftentimes the heart becomes less efficient and isn't able to compensate for that stiffening, and people build up fluid. So one of the most common causes we see of heart failure is atrial fibrillation. And if we don't treat the atrial fibrillation, oftentimes the heart failure doesn't get better. We have a lot of medications we can treat heart failure with, specifically heart failure with reduced ejection fraction. There are 4 main classes of medication we use to help strengthen the heart muscle that have been shown to decrease mortality from heart failure, to decrease people getting admitted to the hospital with heart failure. But unfortunately, if we don't treat the atrial fibrillation, oftentimes people still end up with that weak heart muscle and still have symptoms of heart failure no matter what we do. So getting back to our patient, so she's admitted to the hospital, she gets treated with diuretics, she gets given medication to slow the heart rate down. She's put on some other medications to help the heart pump a little bit more efficiently, but she's still having symptoms. Her heart rate goes up every time she walks around, she's tired, she's fatigued. So Dr. Ibrahim, what would you recommend in this case when you're taking care of this patient? What's your next step?
So there are multiple different strategies where we have to control the electrical system in this situation. In the interim, for now, a good option for her would be a procedure we call cardioversion, which is not even really a procedure. It's much quicker than that. But essentially, it's electrical reset of the electricity in the heart, to simply put it. So pretend you have a frozen computer screen or something, and you push the button and you restart, and things get better. Eventually, patients would come to the endoscopy area, sort of the area where do these things. You would have intravenous line placed, and they would get sedatives and medicines to make you feel very comfortable. You're not going to really feel or notice anything different. And then eventually, through these pads we put on the chest, on the upper and lower chest there, we would deliver a certain amount of voltage, and that voltage would then reset the electrical circuits in the heart in that chamber that's been driving the heart rate very fast. Now, sometimes with this procedure, because it's very important for us to not promote movement of that clot in that chamber, the appendage. So sometimes with the cardioversion, we'd have to do an internal ultrasound or a transesophageal echo, because we get a closer look at that appendage and make sure no clot is there before we do the cardioversion. Which is also the reason, someone who would be getting cardioversion would have to be on blood thinners before and for sure after, because that's also a period of time where clots can form in that appendage. And then there's also additional therapies, and we'll jump into that to some degree.
Great. So one thing I always tell my patients about cardioversion, we see on TV these very dramatic scenarios where people say clear with the paddles on the chest, and it's this big dramatic thing. This is much more calm. People are totally asleep, and we use pads on the chest, and it's a very safe, common procedure that we do very routinely. And like Dr. Ibrahim mentioned, we often do it with that transesophageal echo, which is, can have some discomfort, but people don't feel, and you're totally out and you wake up in regular rhythm. So it's a very safe, comfortable procedure for people. So, but sometimes it doesn't actually last for very long. So that's the problem with atrial fibrillation, is it does come back. And so in our case, this patient gets discharged from the hospital, she goes back into regular rhythm, and she gets put on some medication. She's on a blood thinner called apixaban, which is a common one we use. She's put on a diuretic, furosemide, metoprolol to control the heart rate, dapagliflozin, which is a SGLT2 inhibitor, one of those medications I mentioned that can prevent heart failure, spironolactone, another medication we use to treat heart failure. She initially feels better, but about 2 weeks later, she gets an alert on her watch that says she's back in atrial fibrillation. So, Dr. Kim, what do we do next for this patient? What are our treatment options?
Yeah, I'd like to maybe take time to just kind of think about how we really manage our AFib patients. There are really 2 general approach. So one approach is what we call rate control. So when someone's in atrial fibrillation, it tends to raise your heart, and the heart rate just goes up really high. So the focus of that approach is, let's just control the heart rate. whether the person is in AFib or not, we just control the heart rate first, So there are specific clinical scenarios where we choose to just do that approach. And there's the other approach, which is what we call rhythm control strategy, which is, we use some specialized medication that really help your heart to stay in a normal rhythm, or we do procedure called ablation to really kind of help your heart then stay in a normal rhythm. So the purpose of that approach is to really maximize your time in a normal rhythm, So in going back to our patient, so clearly she's having recurrence and this AFib case coming back, and we are worried that last time when she went into AFib, she also had a heart failure exacerbation too. So, it really had direct consequence on other health issues for her. So, when we look at actually the literature for especially patients with atrial fibrillation and heart failure, we have very strong data to suggest that doing rhythm control strategy, trying to keep them in a normal sinus rhythm, actually, compared to just controlling the heart rate, has benefits in terms of that approach will make them live longer, so less mortality, less number of hospitalization for the heart failure as well. And also ablation in general, compared to medications, we also learned that, it increases your chance of actually staying in a normal rhythm compared to just the rhythm medications. And also it actually increases your chance of improving your heart function if you're one of those patients who had a reduced heart function because of the atrial fibrillation. So I will have all this conversation with this patient, and my recommendation for her would be to consider ablation procedure.
Great. So can you explain a little bit more about ablations and newer catheter techniques that we use?
Sure. So in the picture, you can see that person laying there. So that's the patient. So the catheter ablation for atrial fibrillation has come a long way. And it used to be that it was very long hours of procedure and people will stay overnight in the hospital. But now, it's a day surgery. You come in, it's a general anesthesia procedure. I would say it takes about 3 hours or so, 2 to 3 hours, depending on how much work that needs to be done. And and then we recover the patient in the hospital for a few hours, watch them, make sure they feel good, and they go home the same day. And what's happening during the ablation procedure is, as you can see on the diagram, so we access the large vein in your leg. And then we basically thread in this really thin tubing that's specialized catheters, has ability at the tip to record electrical signals. Some of them have ability to deliver the energy to achieve, what we want to do. These tubing, these thin tubular catheters, we insert them into the heart, actually through the vein. And basically, I told you that atrial fibrillation is a rhythm problem from the left upper chamber of the heart. So then we have to cross from the right to left side, and when we and then we survey the heart and see where the issue is, and when we discover that, then we actually deliver the energy to basically kill off the cells, that's malfunctioning and causing atrial fibrillation. So that's really how it's done. And over the years, we used different type of energy sources to achieve this outcome. Most commonly, we use the radio frequency energy, which creates the heating at the tip of the catheter to kind of kill off the cells, Also, we could use a freezing technology called cryo and also achieve the same outcome. And most recently, we actually have the energy called electroporation. It's a newer energy now that we also use. And again, achieve the same results. But the benefit of that is it's actually thought to be, compared to other energy sources, more tissue specific. So it's more specific to the heart tissue, so that it seems to have less chance of having any kind of collateral damage around the heart. So making the procedure even safer. And I can share with you that in Camino Hospital, we are on top of these newer technologies. We implemented it, and that's the energy source we use for atrial fibrillation ablation these days.
Great. So you mentioned some of the risks involved with this. Can you just mention real quick, what are some of the risks of this procedure? Because it is still an invasive procedure.
Yes. So I usually tell my patients it's fairly standard for any minimally invasive heart procedures when you think about the ablation, procedure risk. So that includes less than 5% chance of anything that's possible, including bleeding, infection, any injury to the blood vessels that we go in, or any injury to the heart muscle, because we are inside the heart working, any major complication that my patient gets all worried about risk of stroke, heart attack, any emergency situations. I always tell my patient, I wish I can tell you zero, but it's very low. Altogether, all these major complications are way less than 1%. And there are a couple other, potential, risk that's more unique to AFib ablation, which is what I earlier mentioned, sort of collateral, injury. So heart has the nerve that's wrapped around the heart that actually supplies the breathing muscle down here. And during ablation, we are paying particular attention not to actually damage that nerve, when we are ablating the areas that we need to ablate for atrial fibrillation. So we always test it, make sure we are not on the way of that nerve, endings. Or, esophagus, our feeding tube, is literally right behind the heart, and that's very close to where AFib circuit is usually. So we use, temperature, monitoring or cooling device and all these, other technologies to help reduce any risk of the esophageal damage from the atrial fibrillation ablation. But like I mentioned, this newer technology seems to actually have less damage to those surrounding structures because it's more tissue specific to the heart.
Yeah. So I want to really point out that, this has really been a changing field in the last 15 years or so. In the past, we really weren't treating AFib. We gave people medications, maybe they'd get on antiarrhythmics, but ablation techniques in the last 10 years, in the last 15 years have really accelerated. And, El Camino's at the cutting edge of it. She mentioned this new catheter technique, which we've really adopted kind of across the board. So it's a, really neat field, as Dr. Kim can mention, but it's been probably one of the fastest growing and changing fields that we have. So getting back to our case, so our patient goes through her ablation. She does well. And then she comes to you and says, well, am I cured from AFib? And if I'm not cured, what can I do to prevent having AFib again?
Yes. When I have a talk with my patient about atrial fibrillation, one thing I emphasize to my patient is that unfortunately AFib is not a curable condition. It's not like we have some infection and we take the antibiotics and we are fully cured. This is more treated like a chronic condition, like a high blood pressure or diabetes. So, we know that when we take medications and control diabetes and high blood pressure, then we minimize any complications that can come from untreated diabetes or high blood pressure, like stroke or amputations, losing vision, and all that. Same idea for AFib is that since age is one of the major risk factors and we are not getting any younger, that AFib tends to come back. And the nature of the disease is that it tends to be progressive, But I emphasize to my patient that it is important that we control this, whether it's medications or the ablation procedure. Sometimes people need couple different ablations throughout their lifetime when things come back and we do touch-ups, So the idea is that we manage this with the tools that we have to minimize any chance of, other complications that can come from atrial fibrillation. So the main thing is that, we then focus back on the risk factors for AFib. We talked about it earlier. And it's a really whole person approach. We got to address all these things to minimize any risk of recurrence in the future, We got to control the blood pressure well. We got to manage the diabetes well. Let's get the sleep apnea treated. Lifestyle changes, more exercise, healthy diet, all of that play a role in terms of minimizing the AFib. Oh, one thing I forgot to mention is weight loss. Obesity is a really serious problem, and it does actually hugely contribute to AFib recurrence. And that's one thing that we also got to work on too.
Oh, great. So getting back to our case, so the patient undergoes ablation without complications. She remains on Eliquis or Pixaban, which is the blood thinner that we use, and we usually recommend continuing blood thinners after ablation because, like Dr. Kim mentioned, AFib is not completely gone and it can recur, and so the stroke risk still remains in people who've had atrial fibrillation, even if they've had an ablation. And we use the same risk factor calculator to decide whether to keep them. So this woman stayed on Eliquis, but a couple of years later, she developed some worsening neuropathy related to her diabetes. She starts having some falls, and we start getting a little more worried about her bleeding risk. So, Dr. Ibrahim, can you explain a little bit more about how we sort of mitigate this risk of bleeding with the risk of having a stroke when you have a history of AFib?
Sure. So there's a couple of different calculations we use, one of them being the CHA2DS2-VASc to help us see which patients, which is the majority of folks, need to be on blood thinners. There's a whole host of different blood thinners which are on the slide there. In terms of the common medicines, the oldest and previously was used frequently was Coumadin or warfarin, but that, of course, as you might know, someone or have heard, that requires you to have blood work that's frequent to manage how thin the blood is, and it tends to be very variable. A lot of dietary influences, dosages, etc. So it's challenging. Recently, there's this more, novel oral anticoagulants, which include things like apixaban, Pradaxa, all those other medicines you see there. So that is the medical management to help, prevent and mitigate that risk of stroke based on the CHA2DS2-VASc. Alternatively, for patients who have atrial fibrillation who should be on blood thinners, but for one reason or another are not able to be on blood thinners, for example, in this patient here, she was having a lot of falls, that also increases the risk of bleeding. You already have a risk of bleeding just being on the medicine, but with falls, of course, that risk is higher. So for that population of patients in particular, there's alternative to the medicines, and that is a particular procedure which we perform here frequently, and that is the left atrial appendage closure or occlusion. And sort of, I hope you appreciate, I guess, anatomically too, all these things are very close in space together in that one chamber. So where the ablation would happen, this is that chamber, or the bunny ear part of the chamber right next to where the ablation would happen. But that is called the appendage, sort of just a evolutionary, chamber that doesn't provide function really to the heart. But in either case, that's where those clots would form, as we alluded to before. So what we do now is this percutaneous closure of the appendage. So to put it simply, it's essentially like patching a hole in the tire or
A left
pothole
atrial-
on the road. You will show you the video in a second, but I'll let the video show you. I'm happy to go up there and point, but a very similar process. We go through the vein down from the groin. You
Yeah.
get started.
Yeah. Okay. So we're going to just watch the video.
Yeah.
Oops.
We have a couple minutes. I'm not
Hold
sure
on.
if I'll pull Dr. Alvin's moves.
You
you
mute
know.
it.
A left atrial appendage closure device can be used for atrial fibrillation patients to help prevent strokes as an alternative to blood thinners
So
such as
the
warfarin,
goal.
Coumadin.
So eventually we're going to come
In-
from below. Yeah,
Yeah.
you could mute it. Yeah.
Yeah, we'll mute it. Go through
That's
it.
okay.
I think it's a little better.
I figured it's better to get up, exercise, right? Healthy lifestyle. So you come up from the vein down in the groin and the leg, as you'll see here. That's just showing you that risk of stroke. The clot was in the appendage, and it can go with the blood flow to the brain and cause a stroke. So we enter the vein down in the groin. That's called the femoral vein, where Dr. Kim would also be doing the ablation procedures from. And eventually, through a series of steps, deliver this catheters or tubes, right? And then we have to cross from the right side of the heart to the left side of the heart. Pretty simple, and we use, of course, under general anesthesia and that ultrasound to help us see in space what we're doing, and eventually guide our tube to that opening of the appendage, and then eventually the device will come out of it. These devices have a lot of intrinsic energy, so they just expand once you release them. And the idea is you want a tight seal here, and so you occlude or exclude that chamber altogether from the heart, and that will close itself over time, and the heart will actually build a small layer of cells over it, so it becomes totally, oblivious to the heart. It's not there anymore. You will still need to be on blood thinners for some time. The body, all these healing processes need you to still take the medicines, but eventually, several months down the road, we get rid of the blood thinner, Eliquis, Xarelto, Pradaxa, etc. And we eventually also would do an echocardiogram down the road, but you would go home the same day. Usually 4 or 5 hours after, you'd be able to leave, and then we would tell you, take these medicines until we talk more in clinic. But general anesthesia with the echo, but pretty simple and common enough. So that's
Great.
that.
So one of the things that I want to highlight about this procedure is it's really a conjunction with an echocardiographer. So there's an imager who has a probe, echocardiogram during the procedure. The patient's under general anesthesia often, or they are always under general anesthesia, and they use, it's a kind of combined procedure, usually between two cardiologists, an echocardiographer who helps guide the imager, so Dr. Ibrahim, and kind of guides the management and really,
Absolutely.
finds the right fit and the exact thing. So it's
Yeah.
a pretty exact procedure. He makes it look really simple in the video.
No.
But I've watched him do these, and it's very exact, and you have to find the right space, the right size, and it's, very technically, he makes it sound simple, but it is a technically challenging procedure, but gets really great outcomes.
Yeah.
So, and
Well, with the help of Dr. Wang, she's usually my eyes in the sky. She's doing the ultrasound for
Yeah.
me. But I hope you appreciate it. It's really a team sport. It's a good team dynamic, and there's a lot of trials going on to these occlusion devices. The most commonly used one is the Watchman device made by Boston Scientific. But there's a lot of studies to see, if it should be more standard or not. We usually reserve it for patients who are at risk, but it's not frontline yet. So for patients who have bleeding episodes, falls that might lead to bleeding, et cetera, these are really the ones who benefit most from the from the device. But
And again, I want to highlight that this is a big innovative change. And when we started our careers, this didn't exist. You'd have to have really tough conversations with patients that, okay, your risk of stroke really goes up as you get older, and we know you have AFib, but you're on this pretty strong blood thinner, and if you're falling and hitting your head, you have intracranial bleeding, you have stomach bleeding, and it's just too dangerous to be on a blood thinner. We had really no other option, and so patients would have to sort of accept that risk that I could have a stroke, but if I took the blood thinner, I could fall and, have a really bad outcome. So they've really changed how we manage our patients and, become much more routine and, much safer to do. And so we have these great options. And so, Dr. Ibrahim, if someone doesn't want to be on blood thinner, they're just worried about being on blood thinner, can they just decide to have a Watchman?
It's a very common question I personally get, because I do these procedures, but at this very moment in time, it's not the standard. There's a lot of trials going into this, but still the first line therapy would be the blood thinners. And only when the situation warrants, then we could delve into discussion about, the appendage closure. But it may well be. It's a very rapidly growing field. It's a lot of innovation, and it's a lot of thinking and people who are investing into this, time and organization. So maybe in the future. But, offhand, first intervention to do the procedure is not the usual scenario.
Mm-hmm. Yeah. Okay. So I think we have a little bit extra time for some questions.
I'll go ahead and help.
Yeah.
First of all, let's have a mercy stretch, because you guys have been sitting for a long time. Just a little stretch.
Does mine count already?
Yeah,
Can
you
we do
too.
some
You too.
stretching?
Yeah. Everyone do a stretch. This has been like a long movie. Hopefully you feel, But this just in from our remote audience, my audience of one, my wife said, this is much more interesting than last year. So I don't know. That's what she said. So I don't know. So we're getting,
Take that offensively.
yeah,
You're part of last year.
Yeah. Oh, I know, huh? No. Anyway, so she's liking it. I hope you are too. Okay. Oh, and she told me I need to complete my thoughts. She had a critique, by the way. So that's a problem I have. But anyway, okay. So we can ask some questions here. We don't have any online, but we have a patient here. Do we have the microphones? Yeah, come on over. You may recognize this gentleman. He was in one of our videos earlier. Dr. Mr. Busrai, I think. Anyway. Okay. Is the microphone on? Okay.
Oh,
It's not working.
Not working.
Maybe, I don't know. It's okay, we got it now. Is it turned on? Give him the other mic. Yeah, thank you. So after this, we've got the patient story, and then you're free. So this
Home stretch.
home stretch.
No.
Boy, we're having difficulty with that
no.
mic.
Maybe you can.
Maybe
you can
just
repeat
let
the
me hear
question.
your question.
Yeah.
What-
First of all, thank you for a wonderful morning. Really enjoyed seeing the audience member here.
Yeah.
But my question is, should I just sort of explore whether I have I'm a candidate for AFib? Should I have 2 stents? I'm sort of generally in good health, but
Yeah.
do I know if anything's happening? Should I go be proactive about this?
Okay, so
About
I'll just
AFib.
repeat the question.
Yeah.
So essentially the question is, should we be proactive about monitoring for atrial fibrillation in people who have risk factors? So people who have heart disease, people who have other risk factors. I think that's an excellent question. And, you know, these days, we didn't go too much into this, but we did mention that our patient had an Apple Watch. And so these days there are devices and there is the ability to monitor patients pretty closely. So I don't know if you have anything to add about monitoring devices, Dr. Kim, and what you recommend for your patients.
Yes, I mean, if you do have many risk factors that can increase the risk of atrial fibrillation, I think it's a good idea, to be honest, to use one of those wearables or devices to do the rhythm monitoring, especially if you also notice that you may have some symptoms here and there, but it's not always detected when you're seeing your doctor, so they don't know, but you do feel something and you do have risk factors. I think it's a good idea to have Apple Watch. There are a lot of smartwatches out there, but to be honest, the Apple Watch has the best algorithm in terms of detecting atrial fibrillation. There's also the devices that actually pairs with the smartphone, and it comes with a little electrode. It's called Cardia, and if you do feel the symptom, then you can put your finger on it and actually records the rhythm too. So. My experience is that generally, it's not 100% accurate, unfortunately, but I think it does a pretty decent job. And it's more sensitive than specific, meaning that it may call false positive for AFib. But certainly, if you do see those results, then you can always bring back to your physician to review it manually to see if that's really true, AFib or not. But I do think it's a good idea, especially if you have multiple risk factors and if you also have some, intermittent symptoms that makes you think about AFib, to have those monitoring devices.
Mm-hmm.
All right.
And one thing we didn't talk about that I did want to mention is sometimes we get patients in the hospital who come in with a stroke and we don't know why they had a stroke. Mm-hmm. They come in and we find out they had a blood clot to their brain and we don't know what caused it. And so one of the most common questions we get is, should we do some more heart tests to see if they have AFib? So there are devices that actually people get discharged from the hospital with the recommendation to get a monitor from their doctor. So we get, patients sent to us, they wear a 2-week heart monitor, doesn't show AFib, but they only wore it for 2 weeks. And sometimes this patient was symptomatic with AFib. One thing we didn't mention is that a lot of patients actually don't feel a thing. They may, unless they're checking their heart rate, unless someone's doing an EKG on them, they may have no idea they have AFib. And so we do have other monitors, which Dr. Kim can talk about and which she puts in these patients who require longer term monitoring where our suspicion is high that they have AFib and it most likely was a clot from the heart. But unless we catch them at the moment in time that they're having AFib, we don't know. And so watches can pick it up sometimes, not always, because people don't wear their watches 24 hours a day. So do you want to talk about loop recorders?
Yeah, so AFib, when it starts out intermittent. That's why sometimes we get lucky to catch it or unlucky to catch it, but you may miss it, So for patients that we have such high suspicion and who, as Raabia mentioned, who already suffered a stroke and our suspicion for AFib is really, really high for the patient, and we do these 2-week monitors, but it doesn't really show AFib, then there is a little monitor called the loop recorder. It's literally half the size of my pinky. It's a small metal device that actually has battery life up to 5 years. And we actually implant that under the skin on your chest. It's a very simple office procedure. And when the battery runs out, we just take it out. Basically, it's there all the time to detect any abnormal rhythms. Also has the ability that if you feel something and you want to correlate your symptom with potentially some rhythm issues, that you can actually then mark it. You can send the transmission to your doctor, so that it's a great tool that can actually pick up the AFib that is a little bit more sporadic. That's hard to catch with the regular monitors.
Mm-hmm. Great. And I think with watches, it's interesting. Sometimes patients would never have known they had AFib. Their watch tells them. And so, they picks up incidental AFib all the time. And so, it really has changed, again, how we manage patients. So,
Wonderful.